Osteoperiosteal is when you don't have no skin attached to it. You're just moving the bone. Okay? Corticoperiosteal, free fibula, or myocutaneous corticoperiosteal, free fibula. But you can do both of them. Okay? Myocutaneous, distally based, and proximally based. Okay? Perforator. Okay? Means what? That you can have skin and muscle. It could be distal, a distally based perforator or proximally based perforator. The fibula mid tibia, the surface of it, what muscle do you have? On the surface of the fibula.
Longus.
So you have longus, PL and PB. So it means what? What is the blood flow to those two?
Peroneal.
Peroneal, okay? So that would be peroneal artery. What about deep in the inside of the fibula? What muscles do you have attached to it? At this level, and at this level, and at this level. Let's review anatomy. Let's start proximally. What do you have right underneath the common peroneum? What is the first muscle right there?
Flexor digitorum.
No, that will be here. That will be mid tibia.
Okay.
Mid tibia. So let's start with the proximal. What is right there by the common peroneum?
Soleus and gastro.
Soleus.
The
You got it. So in the surface gonna be PL, okay? PB. So you're gonna have peroneal artery, but then you have soleus. And if you have the soleus, then it's what?
Tibia.
The lateral soleus is blood flow is what? Lateral soleus. What is your blood flow to the lateral soleus?
it's still peroneal.
That's right. Peroneal artery. The medial soleus, posterior tibia. Okay. Okay. What about the deep? What do you have anything on the deep inside of the fibula at that level? Do you have any of the deep compartment musculature attached to the fibula?
No.
What about the popliteus? So just the soleus?
No. I think it's just a soleus. I must be wrong.
I think the popliteus has some attachment there. I'm not completely sure right now, to be honest with you.
I don't think so.
But I think it's
Matter.
yeah, I think so. I think that here on the deep side, you just have the it will be mainly the soleus, which is gonna be peroneal also. Okay. What about mid tibia? You have the PLPB, and what about in deep?
Is that right?
Mm-hmm.
You said
Mid
the
tibia,
Yeah. Flexor.
flexor. That's right. That one is a flexor hallucis. Flexor hallucis longus. Okay. So that means that if you are taking a portion of the fibula, the mid tibia, your flexor hallucis is gonna be compromised. So you have to tell the patients about it.
Oh, okay.
Okay. So then what happened? You're gonna depend on what? On the brevis.
Mm-hmm.
Okay. So maybe you may have the extensor may just take over.
Yeah.
Okay.
Do you do a prophylactic fusion or anything?
No, if it happens, for the most part, you don't have to do anything. For the most part, you don't have to do anything. Worst case scenario, then you just fuse Okay, so boom, boom, boom. So we have the flexor hallucis that it goes from the mid tibia, okay, to the distal tibia. Okay, so that takes you here again. So you have PB, PL, PB only, no PL, PB, then flexor hallucis longus. Okay. Any other muscle here?
Tertius.
You got it. Peroneus tertius. Yeah. Peroneus tertius. So that means where is the blood flow of the peroneus tertius coming from?
T peroneus.
Yeah.
Tibialis anterior. Okay. Anterior tibial flexor is PT, and this is PB. So basically, what exactly this leads us? That the most vascular portion of the fibula is distally.
Okay.
Okay, so that means what? Let's do something with it. So, if we do it as a myocutaneous perforator, means that I'm gonna do the drawing right now. Let's go from the side here. The fibula. Okay. So if we take the fibula, the most common way that Larry is going to be looking at this now is for revisional ankle fusion or TC fusions. Okay? And when we get a patient, we do it this year, okay? That requires that. So imagine if you take this portion of the fibula completely out, okay? Then it has the flexor hallucis attached to it.
Mm-hmm.
Corticoperiosteum, myo, because from the muscle.
Mm-hmm.
Peroneo, a posterior tibio perforator flap. Okay. The further you go, so you go from here now, you have the arc of rotation. Can go up to here. It can go up to here. Because in ankle fusion, this part, revision, is all destroyed. But usually this part is good. So now you're gonna bring it from here to here. Okay. Larry has a case now coming up already. That after the lab that I told him just take this off. Take this off. Okay? And then this is gonna be cut in half. So in other words, it's gonna look like this. This is your muscle. Okay. You see what I did? I cut it. Then this portion will go right here, and this portion will go right here.
Whoa.
Okay. So now we go to the 3 type of fusions. I asked this question over there to all the fellows, and they were like stumbling. It's like, you have, what is it? First type of fusion. How you can accomplish a fusion by what? There's 3 different type of fusion type. Curettage,
Okay.
Oh.
Planing.
resection, and what is the third one?
Arthroscopic.
No, that's a method. I'm not asking for
Chemistry.
method. No, you have.
What does it start with?
Curettage, resection.
What does it start with?
And what is the third one?
What does it start with?
So like
T.
fish,
You start with a T.
trephine.
Trephine. Exactly.
Good job.
So you have 3 different type of fusions. What is the advantage of the curettage?
No shortening.
You got it. Not shortening, okay? What is the disadvantage of that one?
Don't get enough of subchondral plate.
You got it. So inadequate, break of the subchondral plate. Okay. What about the advantage of the resection?
You get the subchondral plate.
You definitely get the subchondral plate. You get some shortening, but it's excellent for major deformities.
Yeah.
Major deformities and revision. Okay. So then, what is the advantage of the trephine? No shortening.
shortening, yeah.
No
Yeah.
shortening. Okay? No shortening. What else? Another advantage.
You can account for deformity, right?
You cannot really do too much trephine if you have a very bad deformity. So you have
Okay.
to have, that's consideration, mild deformity or no.
Okay.
But minimal. Minimal. Because in reality, if I want to do a trephine arthrodesis from here to here, the only thing I have to do is ring all this together.
Yeah. Okay.
Put a big allograft right here, or put the fibula right inside, and I can do a trephine arthrodesis. And if you put blood flow inside, it's like an internal bone stem.
Yeah.
So this is where we're getting. So I want you guys to, on Wednesday, that we can dissect that fibula like that, muscular, like this. Then we review the blood flow, okay? So you guys feel good about this? That book that I put in the chat room about major fusions, it have a great chapter about this stuff. It's a whole book about complex fusions that I put like 300 pages. It has some great diagrams, great diagrams.
Nice.
It's on the chat room. I think I put it a long time ago. You may not have it.
Okay.
I will look for it and send it to you. So then, if we look at the leg this way, okay, and then tibial tuberosity, and then we have so you go from here 5, 1, 2, 3, 4, 5. Let's say that you have the 5, 10, 15. Okay? So right here, behind is the septum, posterior border. So you're gonna have a blood flow right there, the perforator. Right on the septum, you're gonna have another one. Right here on the septum, you're gonna have another one. But what happened? You have the gastro coming here. So this sound may be louder than this one. But we know the size of that one is bigger. So if you're gonna do a free tissue transfer, you wanna go after that perforator. You wanna go, perforators are between the 10 and 15 because they have higher lumen, easier. So when you harvest the fibula, you're gonna find a perforator that is coming into the posterior septum. So it's gonna be from, now you have the skin paddle, okay, you have the dermis. Okay, so this is the skin, this is the dermis, then this is the adipose layer, okay, then you have the fascia and septum, okay? So I'm simplifying this significantly. So you have, I'm gonna go from here to here. So you have like this, you cross over, it goes all the way here like that. It has perforator here, it has perforator this way. This is gonna come with this one. They're gonna merge together. Okay, these are called the choke vessels between the two perforators, okay? 5, 10, 15. So you can, if you're gonna grab the entire fibula, you wanna go 5, 15. Okay? You wanna grab as much perforators as possible. So how you gonna mark this 5, 10, 15? Simple. I'm making this the most highly difficult flap simple. 5, 10, 15, okay? But keep in mind that you have the septum right here. You have another septum here. It's the anterior border. That perforator there, okay? I'm gonna imagine like that, okay? It's gonna cross over to the top of the compartment, and it's gonna be crossover with this perforator. So it's gonna go under the muscle, and it's gonna go over the muscle. So it becomes septal perforator, then becomes a muscular perforator. Then it goes through the roof, and it gets to the fascia, dermis, and adipose layer and skin. You guys follow me?
Yeah.
But that perforator, if I leave the muscle right there underneath the fibula, on top of the fibula, I'm gonna find a perforator that is gonna pierce the anterior septum. That one is coming from the anterior compartment. Okay? They
Okay.
connect on top of the periosteum.
Gotcha.
So keep in mind that this crossover or inter crossover perforator flow comes intramuscular, subperiosteal, okay, and then also at the level of the fascia, okay. But the main ones are gonna be the ones that you're gonna be always keep in mind are basically gonna be the ones on the perineum. If I follow this perforator, okay, and this is skin, and this is bone, okay, this is the fibula, okay, this perforator is gonna come here, it's gonna go through the posterior septum, and it's gonna go underneath, deep behind the fibula. Imagine then your perineal flow is gonna be right on the center of the fibula. Which muscle protect that perforator perineal flow is the flexor hallucis. Okay, so the flexor hallucis has two bellies, and the perineal artery goes right underneath those two. Okay, so that's the reason why that when you basically take the fibula as a distally based muscular fibula with the perforator from the posterior tibial is a flexor hallucis. You're gonna be leaving behind completely your axial flow. You don't want to take the perineal with you. So you have to open the muscle belly of the flexor hallucis to then take the perineal flow, so then you don't sacrifice your axial flow, because you need that perineal flow all the time. You don't want to take this muscular way, sacrificing your axial flow. So the muscular fibula is an axial sparing flap procedure. It's gonna be purely muscular, and what happens is that then at this point here, the flexor hallucis is gonna be posterior tibial. But you know what? The flexor hallucis right here in this area is gonna have also some perineal flow. So in reality, distally, it's gonna be perineal artery and posterior tibial. Okay? So don't forget that the free fibula, you take the axial flow with you. So when you do a free fibula, you need to be sure that your anterior tibial and posterior tibial are good, because you're taking the entire perineum. We know the perineum is the most strongest one. When you do the free fibula, you have to put a syndesmotic screw. Okay? You're gonna cut the fibula for muscular or free, this angle. 5, 10, 15. So you're gonna go this way and this way. Okay? So far so good?
Yep.
Okay. So what muscles you have on top of the fibula right there?
Cranials.
Okay, so those two are coming down. So you basically find the border, anterior border of the fibula, you bring both muscles down. Now right here and right here, you find that location by your Doppler. Okay, you're gonna put a Homan underneath and another Homan. You're gonna make your cut. Okay, perfect time to maybe do a Masonic. You don't even have to worry about damage your perineal flow behind.
Yeah.
Another great case that Masonic may be great.
Yeah.
By the way, I need to reach out to the Masonic guy to be there on Friday, so we can do it on the lab on Friday.
Oh yeah.
Yeah.
That'd be great.
Okay, so then you're gonna put a Homan underneath, and you're gonna make your cut this way. Okay? You have to cut right here the posterior septum without any damage to the vascular flow. Then what is really the attachment right here in the front of the fibula? You have what? The anterior septum. And what else? It's an attachment. It holds the fibula in place with the tibia.
Osseous, interosseous.
The interosseous membrane. So now imagine that you have, and this is your fibula right here, okay? So this is your anterior compartment, okay? So you're basically gonna go inside right here, okay? You have your extensor group right here. Now, this is really the interosseous membrane right here to get to the tibia.
Mm-hmm.
So you're gonna transect the interosseous membrane from here to here. Okay? Now, because you cut the fibula this way, now you're gonna translate the fibula that is gonna look like this. You follow me?
Yep.
Now the fibula is gonna look like this. Okay. Okay. You follow me?
Yep.
Okay. You're gonna have attachments here. Okay. Those attachments are gonna be from the fascia of the soleus and the gastrocnemius. You're gonna cut those. Okay. Now the fibula can do this. In case you have a tibial defect, this can just be moved there also. That will be medialization of the fibula. But we're gonna take this out, okay? Once we have the Hohmann right here in the canal, take a bone hook,
Mm-hmm.
pull. Now you're gonna see right here in this area, your pedicle. Then you're gonna have your flexor hallucis. And the pedicle is gonna go underneath. You're not gonna see, you're gonna see that portion there, and then this portion here. Okay. So you see, you're gonna see a pedicle here and a pedicle there.
Mm-hmm.
Put a vascular clip right here, or dissect a little further behind the fibula so you can get more length, in case you're gonna do an anastomosis dystole. So for a free fibula, I will put a vascular clamp here, cut here, and now everything goes out. And then this is what I do for the vascular anastomosis. If it's gonna be distally based, you leave this one there. You leave that one there, you're not gonna cut anything. What you're gonna do is you're gonna open the flexor hallucis. Open it up. And then you're gonna see the pulse right here. You're gonna dissect right, skiving the muscle, the bone. Okay. And you're gonna leave the muscle right here attached, the flexor hallucis. And at that point, it's out. I did that for them in the lab. 15, 20 minutes max. It's not difficult, it's just step by step, like
Mhm.
that.
Mm-hmm.
So, this is the general concept that is good for me to review it. But then when we get in the lab, so we do it this week twice,
Okay.
then you do it again, we have 2 links on Friday, so that will be 4. And then if you can do another 2 this weekend, that's 6 in 1 week. All of a sudden, everything in your brain is
Mhm.
boom, 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 boom. And then we can probably, for the symposium, create the best shots of it and create a sequence for it,
Yeah.
so then everybody can benefit from it.
Yeah, it's a great idea.
What do you think?
I love it.
Powerful.
That's awesome.
Okay. So you want to do a trephine arthrodesis? The easiest way is take a rigid reamer from any of the nail company. Go right here like this. If it makes you sleep better, take a burr,
Mhm. Yeah.
and then you just, all this is gonna be open.
Yeah.
Okay, so then when you come this way, you're gonna keep the perineal flow coming this way. So your approach will be, you're gonna go this way. Okay, I'm gonna make the approach a different color. You're gonna go this way. Your surgical incision will be between the two. Then it's gonna go this way. Then it's gonna go this way. And this. Like that. A lateral extensive. Lateral extensive approach, okay? So then you elevate everything this way, and then you have all the exposure that you need.
Nice.
Okay? So this is gonna be a combination of a curettage and trephine arthrodesis.
Okay.
No resection, you maintain length. Okay? If you are doing a talectomy for whatever reason, then perhaps if you're not gonna do lengthening and you wanna maintain length, take the fibula and just put it right there. Muscular, of course.
Mhm.
But that was me on the on telling him, okay? Then Larry goes to a concert, okay? With his family. And I'll tell you how involved he was in the concert. While he was in the concert, he was showing me this case that he want to find out what to do with this, with the
Oh my
with the
god.
head. Yeah.
That's funny.
See.